hello, everyone. Thank you for joining us once again. This is the fourth edition of Newslaundry's series, COVID-19 Dealing with the Second Wave. I have two very eminent panelists with us today. I'm just going to quickly introduce them. We have with us Dr. Priya Sampathkumar after popular demand. She is an infectious disease physician and chair at Infection Prevention and Control at the Mayo Clinic. We also have with us Dr. Sumaiya Shaikh. She's a neuroscientist with a PhD in medicine from Sydney and currently holds a postdoctoral fellowship in Sweden. She's also the editor of Science on the fact-checking portal Alt News that I'm sure you all know about. The format of this is going to be, I'm going to do some warm-up, question and conversations with my panel for about 20 minutes. And then I want you guys to come in with your questions. So this is really about you guys asking questions and having them answered. I wanted to begin with Dr. Priya. We are still in the grip of a very intense second wave. We're losing about 4,000 people a day. This is only the official estimate so far. And over the last 2 weeks, we've had an intense focus on the use of steroids in medication, in COVID care. You had the AIMS doctor saying that it could be one of the reasons behind the black fungus infection, which is fatal. And there's also some talk about excessive use of steroids also leading to deaths. So what do we know about use of steroids? When should it be used? And what is the general knowledge we've gained so far on the use of steroids while treating patients?
So steroids are absolutely life-saving if used correctly and used at the appropriate dose in COVID. So the COVID infection is a multi-phase infection. In the early part of the infection, soon after you're exposed to the virus starts replicating, and that replication can continue for several days until your immune system starts fighting the virus. So in that initial phase of virus replication, you generally have mild symptoms. You may have fever, you may have some body aches. You don't have at that point any significant lung involvement enough to give you low blood oxygen levels. So during that phase, if you give steroids, the steroids can actually be harmful because they're allowing the virus to replicate further. Steroids are helpful in the second phase of the illness when your immune system is now trying to attack the virus. And in attacking the virus, it also causes so much inflammation that your lung tissue is inflamed. And as a result of that, your oxygen levels go down. So during that phase, steroids mute that inflammation and can be life-saving. So because steroids are useful at that point doesn't mean that giving it early or giving it for longer than necessary is helpful. The ideal duration of steroids is somewhere between 5 and 10 days. There's absolutely no benefit beyond 10 days. And most often 5 days is enough. And the dose that we recommend is a moderate dose. So the equivalent of 6 milligrams of dexamethasone. You can, viewers can look up the equivalent doses, but that's a very moderate dose. And at that dose, as I said, it can be life-saving. So giving something that is good, giving it for longer than necessary or giving it at higher doses than necessary is the problem. And that is what we want to get out to people.
Is there a correlation with the black fungus, which is really, everyone's talking about that now,
absolutely.
And steroids?
Yeah, so absolutely. So steroids suppress your immune system, make it more difficult for you to fight off infections. And the black fungus is a mold that is present in the air all around us. It varies in different parts of the country. It varies at different times of the year, but it's generally a ubiquitous fungus. It's there all around us. We breathe it in, our body's immune system takes care of it, and we don't have any problems. But certain groups of people can go on to have infection with this fungus, and those are people who are highly immunosuppressed. So this isn't unique to COVID. People who've had cancer chemotherapy, people who've had steroids for other reasons can get this infection. People who have uncontrolled diabetes also are at high risk for getting this infection. And then the overuse of antibiotics may also be playing a role. So normally our sinuses and our lungs do have bacteria in them. This is part of our normal flora. And getting a lot of antibiotics can kill those bacteria bacteria and allow the fungus to grow more rapidly.
Okay. Okay. Sumaiya, you've been looking at misinformation on corona from the first wave itself, and you've been doing some great work with Alt News. I just want to sense from you on what are the major types of misinformation that you've encountered in the second wave. Is there something that strikes out to you in terms of what people are consuming?
Yeah, thanks, Manisha. I have been looking at both waves, and I think in the first wave, the majority of the information was around alternative medications. But coming at the second wave, I think less of that is happening, more of information that has been not perceived correctly. This is a general problem because a lot of the times in India especially, the clinicians who are advising medications, they don't agree with one specific set of protocol. And some people are going one way about antivirals, some people are going the other way about steroids. And because of this lack of information or different types of information coming, we're leaving the people very confused. Also there's a lot of online stuff happening, and people are just looking over what do you take and what do you not take. So as Priya pointed out correctly, steroids are very helpful, but people don't understand the mechanisms behind it, and they don't understand that it needs to be taken under supervised, controlled administration only. So people would just pop it at home if they think they are mildly symptomatic, because that is going to help them get better. Now, that is probably the reason we are seeing a lot of different types of problems associated with drugs that may be correct for COVID, but at only a certain period of time. If you take that well in advance, you can cause them to suppress the immune system, as Pia pointed out correctly, and delay the body's own inherent immune system to fight against the COVID virus. Now, there are many, many cases in this instance where people have been taking the wrong medications, especially steroids, and then they're increasing the length of the infection to a much a longer period, as opposed to how it would naturally take its course. Yes, some of them, and we see a lot of young people dying as well. And it is highly likely that people just at home are consuming this information, taking steroids without any prescription because it's cheap, easily available. You can just pop a pill, and going towards more the moderate and the severe cases of COVID, which would probably recover anyway. There's only a small percentage of people who would go to severe COVID and or have mortality associated with COVID, but we're seeing a lot of that, and we're always questioning why is this a lot more young people are dying this time. Of course there is a resources problem. The people who can have preventable death, people who don't need to die, these are preventable deaths, they are dying because of the lack of resources, oxygen in particular. But at the same time, I would say the medications are being circulated that you can take this and this and this. It's a whole list, and clinicians are contributing to it. People who think they know enough are contributing to it. There's information online. All of this is a problem. The second part of it is, of course, antivirals. Antivirals will not work. None of these antivirals have been shown to work in clinical control trials. The reason for that is there is a initial 6 to 8 day period of viral replication in your body. So once you get infected, there is a peak that goes, and then the viral replication subsides. And when it subsides, or just before it subsides, your symptoms start to occur. And that's when you find out that, yes, I might have COVID, and let's get a test. But by that time, it's already too late to give antivirals. So that's the later stage of the disease where steroids might actually help, when initially you may not even know that you have COVID. You might be asymptomatic and you're shedding that virus. You're probably infected, and that's why you need to wear masks all the time. And that's probably the time that antivirals work. We don't know, because we can't mass administer antivirals to everybody. They have their own risks. They have their own problems. So at the first few days, some ex vivo studies, which are not done in humans or animals, these studies have been have been telling us that a lot of these antivirals do work on the coronavirus and the specific type of SARS-2, but they are not effective in humans. We've got large trials to show that, and a lot of the doctors are still prescribing it, which is a really sad condition. So especially when you prescribe them towards the later stage of the disease, when the person is dying, people make every effort and give every single thing available to save the person. And at that time, given how many side effects remdesivir gives, it's really a problem just for the patient to, experience these side effects and go through that end of life period. So I think it's very sad that this is happening.
So which brings me to
I want to make a couple of points,
Sumaiya.
So yes, I agree that patients taking medications at home is a problem, but the bigger problem in India is actually overuse of steroids by the medical community. So again, there's wide misinformation. People are afraid to stop the steroids when the patients are getting better, or even if they're not getting better. Regardless, the steroids are being continued unnecessarily, and especially in the hospital setting is where these steroids are very dangerous because patients are weak. They're not able to, walk, which is an essential part of the recovery phase from COVID. And then again, in the hospital, you're exposed to a lot of hospital pathogens, which are deadlier than anything you would encounter at home. So steroids are extra dangerous in the hospital setting. The other point about antivirals is that all these antivirals that are being used are effective against other types of viruses, clinical syndromes in human trials. None of them have been shown to work against coronavirus. And then the in vitro data, is not something that we should be using to guide therapy. What works in the lab does not pan out in real life. And there have been studies of many of these antivirals that show they do not work. So it's really time for people to pay attention to the science and not anecdotes. The third point I want to make is about the remdesivir. It's not just that it has side effects. It does not work at all in severe disease. It's in very short supply. People are getting black market remdesivir, which we don't even know if it's real remdesivir or not. And people are standing in very, very long lines to get it, which is in itself a super spreader event potentially. So there are so many reasons why we shouldn't be using remdesivir beyond just the side effects. And lastly, the emotional trauma. A lot of people are standing in line trying to get remdesivir. My friend herself, even though I told her dad doesn't need it, tried to get remdesivir, was not able to find it. And the hospital said, then we're just going to discharge him because we can't do anything else for him since you were not able to find the remdesivir. He needed oxygen. That was all he needed. And they dismissed him and he died.
Yeah. Okay. Yeah, no, I agree. That's certainly a problem.
So, which brings me to my next question. Another contentious issue in India is plasma therapy. Does it work or not? Because there are people who, every day I see on Twitter, looking for plasma, requests going out, SOS messages going out. And then there's another side of it where people are saying it just doesn't work. Stop asking for this. Stop, doctors should stop asking for people to get it. So, Dr. Priya, what in your assessment, does it work at all? Is there any merit to people going down that route?
So the way that plasma is being used in India, it is 100% not effective, 100% does not work, 100% is a waste of time, energy, and money. And it's also harmful because these huge plasma drives are taking away from other donations, including red blood cells and platelets, which are actually life-saving in patients with cancer, road trauma accident victims. And apparently there's a huge shortage of blood products in blood banks because all resources are going towards collecting plasma and administering plasma. The very large trials of plasma, thousands and thousands of patients, have shown that plasma has absolutely no role in severe disease. Again, it helps there are very small studies that suggest that it may help in very early disease. Again, kind of like the antivirals, where virus is replicating. If you give people antibodies to the virus, it may reduce viral replication. So early on in the disease, in mild mild illness, it may have a role. But again, in the current situation, you're not getting patients in the hospital with mild disease, and plasma really cannot be given at home. There are inherent dangers to administering plasma, transfusion reactions, so it needs to be given in a monitored setting. And so tying up a hospital bed to administer plasma to someone with mild disease at this point doesn't make sense. So if everything was fine and we had a very few patients, then giving plasma early on in the disease may be helpful. Again, very small studies have shown that it may have a benefit, but definitely no use in severe disease. And all these SOSs that I'm seeing on Twitter are for severe disease.
So when it's critical, so I mean, what would you advise people whose doctors are telling them to get plasma? If you know someone you love is critical and the doctor is telling you that this is going to save their lives, what do you?
And that is why I'm doing these news shows, because right now, all the doctors, all the healthcare professionals in India are so overwhelmed, are so busy taking care of patients. They don't have time to read the literature. They don't have time to listen to these news shows. So I'm trying to reach the general public so that they're not, stressed and seeking out these non-essential items like remdesivir and plasma, and hoping that the word will get out enough so people will start questioning their doctors when they prescribe things like plasma. I really think that all of the education, the preparation of healthcare professionals should have been before the second wave hit. Right now, everyone is working 24/7. They have no time for education.
Okay.
So a very, very clear guideline put out by a respected authority would be helpful. They could refer to it and say, this is how I'm going to treat it. And there's a void, as you know, with government bodies kind of failing us.
So, okay. So Maya, I'm just going to ask, take 3 more questions and then we'll open it up.
I have something to add with plasma. I have something to add with plasma therapy.
Yeah, go ahead.
There was recently a Nature paper that came out recently with respect to plasma. And yes, it might not do a lot of harm, but in cases where we're not actually testing where the plasma is coming from, some of the cases that I'd seen earlier, this is more than 5-10 years ago, plasma therapies actually contributed to different types of other diseases. I looked at it in pain medicine, so it added to some of the pain symptoms where the plasma actually came from, from the original donor. But nevertheless, there are also some benefits to it. But in this particular instance in COVID, what they've shown in that particular Nature paper is that it adds to the different mutations. So not just that it is not useful, in a lot of instances, it adds to the variants in the population. So when you're increasing variants, so as the antibodies or the neutralizing antibodies from the plasma subside, which do subside eventually, what we're seeing is a plethora of new mutations, and that's the last thing that we want. So not only plasma is completely useless at this point, but it really adds to these, very much so these mutations that we don't need at the moment.
So do you think the Indian variant could the plasma therapy be one of the reasons for?
We can't speculate on that. We don't know for sure. Viruses mutate all the time, and regardless of the plasma, they will mutate. But if we're giving plasma therapy en masse, there's a very high chance that these things will add to the further mutations of the virus.
So that brings me nicely to my next question, which is that now we've started our vaccination drive. We'd open it up for people between 18 to 45, but now we're running short, and it's going to be a long time before we vaccinate our population, or even half of our population. Does this mean the virus will keep mutating and become more virulent and evade the vaccine-made antibodies? Basically, are we looking at a situation which is not going to be resolved for a very long time?
Well, yeah, of course, the virus will mutate all the time, regardless of the vaccines. Even if vaccines are given, the virus will still mutate. Yes, as we've seen with the flu virus, if you're taking a shot every single year, you add new strains to the flu shot. So it's the same principle here. The virus will mutate, probably have new variants every year or every couple of months, and we will just have to add new variants. But at the same time, there's a huge misconception that taking the vaccine will not give you a COVID infection. There is absolutely no guarantee about that. A lot of people do get infected after taking the vaccines. What is protecting you from is the more severe versions of COVID. So it's protecting you from the more difficult symptoms that you might get. So you might get a little bit of cough here and there, maybe very mild fever, but definitely not severe COVID or mortality. Or it's a very, very, very small proportion who would, it would be very unfortunate who would get it, but it largely protects you from severe COVID. And that is the benefit of the vaccine. The benefit of the vaccine is not that you'll stop getting COVID. You still get COVID, you still infect others.
But as the virus mutates, which means we'll have to vaccinate ourselves annually. Is that what we're looking at? Like a flu shot is annual, right?
We don't know at the moment, but it is probably likely.
Yeah, so let me address that question about mutations. So mutations happen whenever the virus is replicating. The virus can only replicate in humans. So if we control cases, we will control the rate of mutation. So that's a very, very key concept. One way to control infections is through vaccination, but it's not the only way. All of us today can take actions to prevent transmission, which includes masking, not going out in crowds, making sure that if you have COVID or if one of your loved ones has COVID, keeping them isolated. If you've been exposed to COVID, staying in quarantine. So these are all things we can do even before we have enough supply of vaccines. And this is what gets forgotten. We're talking about booster doses of vaccine when we don't even have one dose of vaccine given to our population yet. And also saying, well, you know, vaccine is just going to cause more variants and giving up. This is not the time to give up. This is the time to hunker down, do everything possible to prevent transmission. That's the way to prevent mutations. If you don't have transmission, you don't have mutations.
So what is happening in India now? I mean, I know from at least two of my friends, they went to get their first jab and then got corona after 5 days, they started showing symptoms. So it's possible because it was very crowded because they went on the first day. Now, suppose you get your first jab and you get the virus. When do you take your second jab? Do you then wait for some time or do you test negative and then you just take it?
If you are more than 14 days out from your infection, you can take the vaccine. There's no safety risk to taking vaccine, the second dose at that time. Now, if you've had one dose of the vaccine and you've had coronavirus, you are protected for some duration of time from a second infection. So because shots are in such short supply right now, I would say, if at all possible, wait at least 3 months in order to save that shot for other people. But there's no safety risk to taking the vaccine.
That won't impact the effect of the vaccine, right? Even if you take.
So it depends on the vaccine. If it was Covishield, then getting it up to 3 months later, the vaccine efficacy is actually higher than if you get it at the 4-week interval.
Okay. Great. And Sumaiya, I wanted to ask you, we've changed our vaccine policy now with Covishield. Used to be, it's now 12 weeks. So is that good science informing our policy, or is it just shortage?
So I don't know whether it's, I don't know what's going on in their heads, you know, but they've changed it to 16 weeks now. And I haven't seen any research study that has talked about 16-week interval between this particular vaccine. But I think what they might be doing is, again, the delay and manipulating that delay can increase the efficacy of Covishield in particular. That has been tested, and as Priya rightly pointed out. But we don't have any data for 16 days. And if that's what's being suggested, I'm not sure where it's coming from. But having said that, these policies have been, there's a huge part of politics in making these type of policies. And the actual policies that need to be made is from ICMR, from, you know, AIMS pushing the ICMR to do the, you know, to study the research and advise them on policy making. And that is really not happening. I mean, last year, I think around summer last year, they were talking about how, oh, there is some remdesivir data that we need to change the ICMR protocol on. And then they kept talking, I think thrice they put the PR out that we were meeting, to change this protocol, and they did not. And I think only recently, when I put a fact check out as well, a couple of days later than that, they did change the ICMR protocol to remove remdesivir, but plasma is still there, ivermectin is still there, and all these other things. So, and but the clinicians there, they're still prescribing. They're like, I'm seeing a change in my patients in my clinic, so I'm going to still do it anyway. But they don't realize that science doesn't work that way. Evidence doesn't work that way. You can't see 1 or 2 patients around you and prescribe something because they're seeing it in working in their own patients, because it is very likely that they're automatically getting better on their own because of their own inherent immunity and with the help in the clinical setting. But this is not, I think the problem is a lot of these clinicians are, again, not reading papers. Either they don't have the time or they haven't been trained to look at science the way that it should be looked at. So there's a huge problem with evidence seeking in the clinicians in this time.
And do we know anything about Covishield and Covaxin, and which one is more is stronger to fight the Indian mutant? Which one is more efficient to fight the Indian mutant? Do you know anything about that?
Yeah, there is data that got published in the Journal of Travel Medicine. It was put out as preprint, I think, end of last year, early January. Sorry, no, it was much later. Sorry, it was much later that the data was put out. And they tested in about 38 people that Covaxin reduced or Covaxin induced neutralizing antibodies with regards to the UK variant, but there is no data for the Indian variant yet. And even in those particular cases, the neutralizing antibodies that were released, they were not really, I mean, in an average population, yes, they were released, and that was above the 50%, which is the WHO recommendation. Then you need to have at least 50% or more for a vaccine to be called effective. But some of these cases that I saw, or because I saw the data, were actually below a 50% mark. So I'm not sure whether it does evoke the neutralizing antibodies in all COVID positive patients with the UK variant, but I'm certainly not sure about the Indian variant because we have absolutely no data, neither for Covaxin nor for Covishield.
So take whatever you get.
So actually, Covishield, there's some early preprint data that shows that there are neutralizing antibodies put out by the Serum Institute of India. Again, this is not clinical data, so we don't know about clinical efficacy. There is lab data that shows that neutralizing antibodies persist against against the Indian variant. Now, the Covaxin, we don't even have the trial data from the wild type virus published yet. I don't understand the delay. There was a press release, and unfortunately, science is coming out in press releases. This was the same with Pfizer and Moderna too. But the saving grace was that within 2 weeks, there were published peer-reviewed trials. For Covaxin, I don't understand why between February and now, there has been no published trial. The last I heard, they said maybe by the middle of June. That is a big problem because right now, none of us have any understanding of the Covaxin data other than the little blurb that the company put out in February. So that's an issue. With Covishield, I think that even though we don't have trial data, what we are seeing in India shows that the vaccine is working. So I've heard of a lot of cases of COVID infection, including in some of my healthcare worker colleagues in India after vaccination. But the good news is they've all been mild. They've not required hospitalization, and they have not been deaths. So again, the vaccine is working the way it's supposed to at preventing severe disease and deaths.
Okay, so my last question to you, and then we open it up. Reinfections. Have you come across reinfections? Are they more aggressive, less aggressive? What do we know about reinfections? Because that's one big fear now for even people who've had coronavirus.
You want me to take that? Or?
Yeah. Go ahead.
So reinfection is real. It definitely happens. And again, when there is mutations, what you're seeing, so if you have wild type virus in the US with the same strains of virus circulating, we have seen a very, very small number of reinfections. in India, with now a mutant strain, a new variant circulating, the reinfection rate is a lot higher because people are not immune to this new variant. Again, because of lack of good data on testing and actual numbers coming out, we don't know what that reinfection rate actually is. And we don't know whether cases are more severe, less severe. It does appear that this is almost like a brand new infection, that there's no correlation between past COVID infection and severity of illness. There's mild cases, there's severe cases. So again, there's a big data void. But reinfection is real and it can happen. And that's one reason why we're continuing to promote vaccination, even if you've had disease. The protection level that you get from vaccination is several fold that from a natural infection. So that's why it's important to get vaccinated, even if you've already had COVID once or even if you've had COVID twice.
Okay. And last question to Sumaiya.
Some data on top of the reinfection. So there's a study that came out earlier that suggested that about 65 days later, the neutralizing antibodies that were found because of an infection earlier was only found in 16% of the population that were having the neutralizing antibodies before. So a large proportion of the people actually do lose their antibodies around that period of time. So if 16% has the antibodies beyond 65 days. So what we're seeing is that is the critical time where you're more than likely to be infected again. But however, there is another study that says that it is not the level of antibodies after you've got the infection, but it's actually the time that it takes to generate, and identify the antigen and generate antibodies again, if you've been infected before. So, what vaccine does is, in particular, it's very important, is that vaccine already keeps that memory of this antigen and produces antibodies as soon as you get the infection. Whereas in a completely healthy subject, healthy person with absolutely no vaccination or previous infection, it takes a lot longer for your body to produce those antibodies. And that's why you see this, moderate to severe cases. So, having said that, people who've had the infection, it is likely that they even if they reduce their antibody load, they might actually have the memory and they might be able to produce it quicker, and that's why the second doses are given. So just kind of tops up that immunity further.
And okay, my last question to you was actually, you started off talking about how in this way we're losing a lot of young people. There's also been news of pregnant women being affected this time, way more than the last time. And for some of us here, journalists, this wave just seems very random in the sense that there's just so much death around you. There seems to be no pattern. Earlier we thought, okay, it was comorbidities, it was older people who were being more affected. Now it seems healthy, young, fit people without comorbidities are dying. Sometimes it's too sudden, deaths are happening within like 24 hours. So why is this happening? I mean, do we have any idea on who is most vulnerable with this Indian variant? Is there any, understanding of that?
Yeah, do you want to take that first? I'll just add on top.
Yeah. So I think we don't know for sure. Again, big data vacuum right now. But you're absolutely right that we're hearing more and more about young people, about pregnant women. So over the course of the last 14 months, we've accumulated a lot of data on what makes people vulnerable to COVID. And one of those is old age, people with weakened immune systems. We know that pregnancy is actually a risk factor for poorer outcomes in COVID. Diabetes, obesity, all of these things we have known about for the last 14 months. And I think we've done a good job of communicating about these risk factors to the public. So my perception, and I might be totally wrong, is that people in these risk groups have learned to be more careful. My in-laws, for instance, who are older, have been terrified and they have not been going out. They have been, following our instructions. They're also in a position to be able to stay home. They don't need to go out. They're not, they're retired, they're not working. Younger people have been given the false impression that they're completely immune, that they are not vulnerable to COVID at all. So they have been behaving in an entirely different manner, no masking, going out in large groups, partying, going to bars, going to restaurants where, the exposure is much higher, going to parties, going to weddings, this sort of thing. And I think that is playing a role in affecting younger people. The other thing is, yes, India has only about 3% vaccination rates, but the bulk of that vaccination has been in the elderly. So a higher proportion of older people have been vaccinated. Younger people are not vaccinated. They're taking more risks. They're also working age adults who have to go out to work and therefore don't have the luxury of sheltering in place at home. So I think these are adding to the fact that younger people are presenting with more disease. The other thing that plays a role is viral load. If you are exposed to COVID from someone who is mildly ill and is masked, you can still get COVID, but your viral load exposure is low. When you're out in a crowded place, when you're talking loudly, singing, etc., the exposure to you from that singer, from that person who's talking loudly is much, much higher. And so disease progression is faster in those individuals. And we saw the same pattern here during our second surge. The people who were coming in really sick were working adults who had jobs where they, could not stay home. They were essential workers. They worked in grocery stores. They worked in meatpacking plants. They were told, you're young, you're healthy, you can work. So I think it's a little bit of messaging that needs to get to young people that you're not invulnerable. You can get COVID. And even if you don't have comorbidities, if you get enough of a viral load, you can have severe consequences.
You want to add to that, Sumaiya, and then I'll open it up.
Yeah, totally agree. Again, this is a huge problem. Everybody is vulnerable. The also problem with India right now is a lot of people are not getting tested. I mean, yes, there is a stigma associated with testing, and what I've been hearing the last couple of days is people just don't get tested unless they actually need to get admitted, which is, going where they face some sort of a breathing difficulty or they think that they need clinical attention. And because they refuse to test, and it's also expensive to test, so you'd rather not. And we've known that the antigen test is not as accurate as it should be. So doing an RT-PCR does cost. It takes time. It takes money. So they'd rather not do that and just stay at home or mask. And in cases where they need to work, they might actually go to work as well. So this is a huge problem where they think that if you're healthy, if you're asymptomatic, you can go without a mask or even with a mask, and you should be always okay. But the reality is that a lot of the asymptomatic cases also happen. And if you don't mask, if you're still exposing a lot more, as Priya pointed out, being out in the open, increasing the exposure to not just to yourself, but also giving the exposure to others, that might increase the possibility of the infection. So young people are absolutely not immune, and we don't know at the moment. It's not just comorbidities. It could be a lot of different things. It could be genetics. We absolutely have no idea why young people are dying, and because we don't know, we're still stuck with the question. If you can work from home, you should be working from home. I understand the problems associated with not working in India because the government really has no provisions for, or no allowance or a benefit, as the UK did, or a lot of the other countries are doing in Sweden as well. There is an allowance, if it's a stay-at-home allowance for those who are sick. Now, if you don't give that benefit to people, they're more than likely to go out and work. And this is a huge problem related to COVID, which is going to increase the spread, of course, in the community.
And I would just like to add that it's not people don't want to get tested. People cannot get tested. The system has completely failed in many parts of India. There is no access to testing.
That's true. In fact, for people who've got COVID, to test whether you're negative or not, I think most people are not doing that anymore because it's impossible.
You don't need to do it. You don't need to get tested to show that you're negative, but you do need a test to show that you're positive to have accurate numbers. And that is not even feasible for many people. It's not that they don't want to, the system has completely failed.
Yeah. And for those who've tested positive, I think it's just 14 days. If you don't show symptoms, then 14 days is good enough. And then you don't need to get yourself tested.
And really, people shouldn't be trying to get tested to show they're negative, because that adds stress to the system.
There is another thing that I've been seeing a lot is that people testing too early and testing negative at the start and then testing positive much later, but they already developed some symptoms. And it was very peculiar because it wasn't coming out as data, but I was hearing it from different people. They had COVID symptoms and they tested negative and things were okay. And then because I think they were testing it too early, and that was also creating problems. The second thing that I've been seeing is that they've been testing negative for days altogether. For example, recently, Indian
this is happening quite a lot.
Yeah, so recently an Indian went to Australia and it was the person quarantined for 14 days, did not test negative at all, did not meet anybody. And just after getting out from quarantine, the person tested positive. And now the person is in Australia in the community where COVID is very much controlled as a positive person with the Indian variant. So this is a huge problem that has been happening. So I'm not sure how to go around this, and I don't understand what is happening here. Did the person take steroids or not? I'm not exactly sure. I can't comment on.
Yeah, this happens all the time in clinical practice. No test is perfect. You get positives, you get negative, you flip back and forth. So I don't think that is really an unusual finding at all.
Yeah, but it's happening a lot frequently.
What if you keep testing it? With one case that I know of, the husband was positive and the wife developed symptoms, and there's no other reason for her to have gotten, the symptoms. And then she kept testing for 2 weeks and it kept showing negative, even though, all her symptoms were.
So test positive. Yeah, it could be a bad PCR test. It could be bad technique in collecting the test. It could be bad transportation. If you have symptoms in India at the present time, you have COVID.
Yeah, I just assume you have it. Okay, we're going to take some questions now. So Korean Matthew says, the CDC guidelines in US talks of mask off approach in spite of finding the Modi variant, the Indian variant he means, in spite of finding the Indian variant. So will it be similar for those who are fully vaccinated here? Basically, if you get vaccinated, does it mean we can follow the CDC guidelines and be fully?
No.
Without?
No. My answer is just no.
Israel actually posted out, Israel has been doing wonderfully in regards to the vaccinations in particular. And it had been, one of the best in terms of the percentage of people vaccinating and how quickly they did that. They released a video recently that people were taking the masks off in front of the camera, and that was to promote vaccination, that this is what you could do. But that was such a misleading thing to say, because that is absolutely not how it's supposed to be. You can't get vaccinated and take the masks off, and that was the promotion video. So I was really sad to see something like that as a government.
You have to wear a mask. There's no even if you get fully vaccinated, there's no way around that. We'll wait for Priya to come back, and then I'll take some other questions. Are you serious? Everything and every treatment conducted so far has been labeled not so useful by you guys. Then what do you suggest? Either get vaccinated or drink hot water and stay put. No, I don't think we said nothing works. I think we were very clear about the fact that steroids are life-saving, but at the right, there's a critical time period at which they have to be administered, which is not early on. And plasma, we've clearly said that it's not useful at all, except when in the beginning and in a very specific dose and right at the beginning. Other than that, I don't think we've said nothing, but maybe Priya can take that.
I would like to tell you what does work. So what does work is staying home if you have mild symptoms in order to relieve the stress on the healthcare system. If your oxygen levels start going down, then you need to get a hospital bed if possible. What works at that point is essential is oxygen. The other thing that works is what's called proning. Just lying on your stomach, it changes how air moves in your lungs. It gets air into the parts of the lungs that are usually not as well aerated. So that works. And then oral steroids work. So these are the things that absolutely work. And then if you are in the hospital, someone had a question in the chat about anticoagulation. So we know that COVID does increase the risk of blood clots. And the fact that you're in the hospital and immobile also increases the risk of blood clots. So until you become mobile again, yes, anticoagulation absolutely works. So these are the things that work. And I don't want you to go away thinking nothing works, but because these things work, that you can't extrapolate that these things work at any point in the time course of the disease.
Okay. Prithvi Chandra, if someone has taken the first shot of Covaxin and can't take the second shot due to shortage, do you advise they wait or take Covishield if available?
Very tough question. There's no data that you can mix and match vaccines. We don't know what the effect of that is. But if you have access to Covishield and you're in a high-risk group, I would say take it for the benefit you get from the single dose of Covishield. Don't assume that that's the second dose of the Covaxin series, but take it because getting Covishield is, we know even one dose is protective.
Okay.
So in the UK, there was a study, only again, very recent study that came out that tested intermixing Covishield, which is the AstraZeneca, and the Pfizer. And that was mostly done in the healthcare workers, I think largely nurses, but a lot of different healthcare workers. And they said it works just as fine, but we don't know if you could mix Covaxin and Covishield because they're completely different technologies. Yes, again, don't assume that the two vaccines are equivalent of the two doses of the same vaccine. But if you're in a very, very high risk category and you probably are surrounded by people who are likely to get COVID, go ahead and take that as your first dose, and then your second dose follow up with Covishield. But no data so far with Covaxin and Covishield together.
Okay. My wife is 8th month pregnant. Should we go for her vaccination or avoid now and wait?
Please go for vaccination. Later stages of pregnancy, if you get COVID, outcomes can be very bad. At 8 months, there's absolutely no risk from the vaccine to you, the pregnant woman, or to the baby. There is because COVID rates are so high, there is significant risk even from going in for your delivery, from going in for your prenatal checks, that you could be exposed to COVID. So I would urge you, if you can find vaccine, to definitely get vaccinated.
Okay. Post-COVID lung sensation, how long will it last?
Post-COVID lung what?
What is that? Is that like a sensation in the lung? You mean like congestion or something? I'm not very clear about.
Well, symptoms can last for a very long time. We've seen it with long COVID. We don't know if there's no set number of days for a single person. So it could be 2 weeks or 3 weeks, or it could be way more than that. If you're talking about how your lung has reduced capacity for oxygen, that could change in person to person.
Okay. What about the fact that steam gargling probably acts as a mucolytic? Not talking about excessive or overzealous use.
So I think it won't hurt if you do it correctly. What I have problems with is the mass gatherings for steam inhalation. I think that's a really bad idea. If these people are infected, for all of them to gather together, again, seems insane. If you do it privately at home, I don't think it hurts. It's really good for your skin too. Opens up your pores. So steam inhalation is okay. Gargling with hot water is okay. They may not help, but they will not hurt. So I think it's perfectly okay. You should not be having mass steam inhalation centers, which I see on TV all the time.
Yeah. So just to add to that, if you have COVID and if you have very, very mild breathing difficulty, you got some tightness in the chest, if you do steam inhalation, it might actually ease you out a little bit, because it's just giving you some moisture. But at the same time, it's not going to cure you of COVID, so there's no guarantee of that. And also drinking hot water in particular, because everybody is rushing to get just, hot water. It's going to give you some soothing relief in your throat if that is a concern, but otherwise it's not going to cure COVID for sure. So all these guidelines should be made clear in, what is the benefit and, what is the risk if you don't take it. It is not essential.
Okay. What are the complications after the second dose of the vaccine, and what can be done to avoid it? I think second dose is fairly easy, right? It's the first dose where you may have fever and sore arm and things like that.
The second dose, actually, you may have more of the local side effects, because again, your body has seen the vaccine before, so you can actually get more pain, more body aches. And people should just be aware that that might happen. And it's a good thing, because all these side effects mean that the vaccine is working well at creating immunity in your body. With the first dose of the vaccine, there's a small chance of allergy that it doesn't happen. If you tolerated the first dose, an allergic reaction to the second dose is much, much less likely. So that's one thing. Similarly, these isolated reports of blood clots generally happen after the first dose. So if you've tolerated that, then getting the second dose, it's very unlikely that you'll have problems.
Just adding to that, the blood clots are only seen in women, and AstraZeneca, for example, is vaccinated about 18 million people, and out of those, a very, very small number of people have got those blood clots, mostly young women, and I think they were like under 30 or something, and the deaths were, I think, 9 or so. I think it was 7 or 9. So the chances of you getting a blood clot from COVID, according to this data, is 0.00016, whereas chances of you getting a blood clot from COVID itself, the disease itself, is a lot higher. The chance of you getting COVID is a lot higher. So if you're waiting to not get vaccinated because COVID vaccine is going to give you some symptoms, that is a very bad analysis. You have to get vaccination first and not wait for COVID to infect you.
Yeah, and someone asked that her mother's got chemotherapy in 2007. She's good and safe. Should she be getting vaccinated? I'm guessing yes.
Absolutely. Absolutely.
So there was a really interesting question from Rachit Dikshit. Can I answer that?
Please go ahead.
So the question was, the vaccine effectiveness is for Sputnik is 90%, Covishield is somewhere around 72%. What does this mean exactly? So when vaccine manufacturer put out data about vaccine effectiveness, it is the overall population. So for Sputnik, in the population that was studied, 92%, there was a decrease of 92% in the people who got vaccinated from those who were not vaccinated. But that's all infections, including mild infections, asymptomatic infections, moderate infections, and severe infections. So definitely Sputnik looks like it's much better than AstraZeneca, right? But that number is not as important. It's important on a public health basis, because if you are using a vaccine that's 90% effective, there's less transmission because there are fewer overall cases of COVID. But for an individual who gets vaccinated, what matters is how effective it is at preventing severe illness and death. And in that, almost all the vaccines tested are close to 99%, whether it's the mRNA vaccines that are used in the US, the Covishield vaccine, the Sputnik vaccine, all of them are equally effective at preventing death, and that's 99%, which is really, really amazing for vaccines. Covaxin has not released their severe hospitalization and death rates, so we don't know how effective it is in that regard. But Johnson & Johnson, every vaccine that has had published phase 3 trials has shown to be very effective at preventing death and hospitalization.
Yeah.
This is a constant worry now, I think. The next question that I'm taking, I think a lot of people are worrying about this because of the vaccine shortage that India is facing. If there's a delay of second dose by months, will it affect a person? So basically, I get my first jab and I'm unable to get the second jab within the stipulated 3 months. Maybe I get it in the 4th month. Does it go waste? I have to again take the first jab
No,
No.
you don't ever need to restart the vaccine series. So I don't think the shot goes waste. In the trials, we know that the efficacy at 3 months was superior. Excuse me. Was superior to the 4-week interval. So that's the trial data. But from the UK, we have real life experience that extending the interval to more than 12 weeks. I'm sorry, I think I need a steam inhalation.
Just drink a little more water and just.
Yeah. So we do have data from the UK that shows that extending that interval beyond 12 weeks in real life does seem to work. Similarly, in the US, all the trials for the mRNA vaccines were, at 3 or 4 week intervals, and the US expert said, absolutely not. We must do 2 doses. We cannot extend the interval. But UK did exactly that. And I think they showed us that in real life, that is okay, that 1 dose is very protective and you can delay the 2nd dose. So in the current situation that we are in India, I would not worry about getting your 2nd dose, get your 1st dose, and then get your 2nd dose when you can. And the goal really should be to get as many people vaccinated with at least 1 dose as quickly as possible. And then one other point, I know we're coming to the end of our time, that I really want to reemphasize. Everyone is so worried about vaccine and when they can get it. And there's nothing like a good shortage of something to make you feel like it's really, really important. But we all have a vaccine in our pocket. I can't emphasize this enough. A mask is like a vaccine. It's just that you have to use it for it to work. While we're waiting for vaccine, wearing a mask all the time in public will be protective.
Okay, I'll just take like last 3 questions. Is there a phase in pregnancy when the 2nd shot of Covishield shouldn't be taken? I'm guessing you've already taken your 1st. So
no.
So you can take the shot at whatever.
Again, the risk that COVID infection is going to give you is going to be way higher. So get your shot as soon as possible.
Can I answer one more question kind of about women?
Yeah.
I get this nonsense question all the time, and I'm sure your viewers are not asking this question, but I still want to answer it, about menstruation and is it safe to get vaccinated? That is complete garbage. There's absolutely no reason why any vaccine should not be given to menstruating women.
Yeah, they were linked with fertility. I've seen some of that misinformation around. We cleared it out. That fertility will decrease.
There is that kind of misinformation that there's a lot.
Yeah, but fertility will decrease, but that's obviously false. That's not true.
Say that louder. Say it once more, Sumaiya, because I think people need to hear it.
So basically, there was misinformation floating around that if you take your vaccine during your menstruation time, when you're bleeding, that's when it's going to decrease your fertility in those women who get vaccinated during menstruation. But that's not true. That is absolutely baseless. That hasn't been looked through, through science. We know it's not correct. So go ahead and take your vaccine whenever it's possible, menstruating or not. It doesn't matter.
Sputnik consists of 2 doses. What should be the 2nd dose? When should be the 2nd dose given? I think this is something you can Google and find out. I think this is easily available information.
4 weeks. It's 4 weeks.
4 weeks. Okay. There's some evidence that shows the 3rd wave is bigger than the 2nd wave. It is being said that the 3rd wave is going to affect children. In this case, should children be vaccinated once the 2nd wave stabilizes? There's concern that children can also be big super spreaders if this does happen. So should children be getting vaccinated?
So let me talk about 3rd wave. 2nd wave, 3rd wave, 4th wave is all in our hands. This is not some sort of mystical thing that just happens like a tsunami just appears. The waves will depend on human behavior. So if we take precautions, we use common sense, we get vaccinated now, there may not be a 3rd wave. Saying things like, well, the third wave will involve children is completely baseless. It'll involve whoever was not taking precautions. It will involve whoever is vulnerable. So if we vaccinate all the elderly, if we vaccinate all the people over the age of 18, yes, then the third wave, if children are not taking precautions, could affect them. But we don't know that, and we can still control things. If adults take precautions, then we can keep our children safe even without vaccination.
So there are many cases itself in the second wave where the children were let out to play Holi and all sorts of things because they thought, oh, they're going to be safe and let them enjoy the festival. But they came home and then infected their parents. So I know a case where just the cousins kind of interacted and played Holi, and they went back home and they infected the entire extended family. Now that was very dangerous, of course. So even now you can still have children's going to different places to play and to school, or whatever's open, and then come back with an infection. So don't wait for the third wave. The children can infect you now. So that's very important that they are also protected.
Okay, great. And as far as vaccinating the children, it's when the science says that it's good to. So far, it's just for 18 and above. So once we have a vaccine that's good for kids.
Well, I think that because children don't get as sick from it, I think that it's really important to vaccinate people who are at high risk of consequences. So between 18 and 44, we have a lot of high risk individuals. We need to vaccinate them first before we move on to children. In the US, that has happened and they've moved on to children. I still think that, the vaccine that's being used to vaccinate children in the US would be better served being sent to other parts of the world where there are huge numbers of cases. But again, I don't make US policy. So.
There is another thing on who is considered at risk. So in Sweden, we consider a lot of different populations that are at risk, especially those are essential workers. You can't leave them out, but not just the clinical workers that are essential. We have people like you guys on the street, reporting, the journalists, and then you have people who are delivering stuff, pharmacists, and all those people are essential workers that we need to have vaccinated.
Farmers are a huge group that are really, we depend on them for our food supply.
Absolutely. So these people, and then what Sweden did in particular was that if a family has somebody at a very high risk, the people who live with them, people who are around them, they also got vaccination. So people who were in the aged care homes, who worked in the aged care homes, and people who were looking after older people living in their homes, they were also at a very high risk and they got vaccinated too. So anybody who had immune system issues, they got vaccination, and then their family got vaccination. So that way you kind of prevent the individual who's most at risk to get this kind of a problem. So I think the at-risk people should be just more than what the 65 and over is. That's not like a good definition.
Okay.
Teachers, if they're taking care of creches and all these places where kids are sent for daycare, for example.
I'm going to take last two questions and I'll let my panel go because I'm sure they have a lot more to do. Aditya says, how long does one vaccine shot last? If I take both shots, how long am I safe? How many booster doses are required to stay safe forever? Wow.
Very
we don't know. Short answer is we don't know.
Okay. But basically just get your vaccine, and like Priya said, and like Sumaiya has also said, you still have to take precautions. So if you want to stay safe forever, just use the other vaccine in your pocket, which is the mask. Okay, I don't know how to pronounce this medicine.
Tocilizumab, yes. Tocilizumab is useful, but in very, very select cases. So it would be a very tiny proportion of patients who are hospitalized, who are getting steroids and show some initial improvement and then deteriorate in the hospital. They are very, very severely ill, are on a ventilator. And again, the window for tocilizumab is small. It needs to be given within 24 to 48 hours of that deterioration. So very tiny of all the COVID cases, a tiny, tiny fraction of them in the hospital under medical supervision. Tocilizumab is what we call an IL-6 inhibitor. It is very immunosuppressive. So again, patients should not have any other infection at that time, no bacterial infection, no fungal infection. They should be screened for those, and tocilizumab given only under those circumstances.
Again, something that only your doctor can administer while looking at conditions.
Absolutely. So it's like an monoclonal antibody, obviously, as Priya said, it's a interleukin-6 inhibitor. Now, of course, as an immune suppressant, you have to only take it under the clinical guidance. But it was used for arthritis and stuff. Because the disease history of COVID is so different, you need to make sure you're giving these things at the right time. Only advice from the clinician. Don't go out and take it from a pharmacy. And
there was also last question. I'll just take it. There was also a question on favipiravir.
No use. No use.
No use? Okay, great. Okay, because a lot of people again asking for that. Fine.
Favipiravir or Fabiflu, whatever. No use, absolutely no use.
Okay, great. Thank you so much. This was really good. And I hope this was useful to everyone who attended it. And thank you so much for your time, Dr. Priya and Dr. Sumaiya. This was really enlightening for me. And I hope for all our audience.
Thank you.
Thanks.